Hey everyone, how's it going? My name is Brad. I'm one of the PGY2s here at USF, and happy to talk to you today about the management of bradycardia here at the hospital. So, kind of have it written here, but defined as a heart rate of less than 60 beats per minute. Kind of the first thing you want to do when you get this call from maybe a nurse, or you're told that the patient is bradycardic. First off is, are they having symptoms? Getting an EKG, that's a 12 lead, or looking at telemetry strip, just to assess if it's sinus bradycardia versus if there's a block. Making sure that the patient has adequate IV access in case you need to push some medications. And then having somebody recycle a blood pressure, either yourself or the nurse, just to assess the patient's hemodynamic status. So once you get that information here, kind of the next step in the whole algorithm is assessing for signs of hemodynamic compromise. So hypotension, shock, if the patient's altered, having worsening mental status, and if there's evidence of some chest discomfort or ischemia. If you do not have these kind of symptoms, what you can do is observe these patients. So if it's a sinus bradycardia, and they're sleeping, just kind of watching them and having the nurse kind of keep a close eye. One caveat here, though, is if the patient's in a Mobitz type 2 second degree AV block, these are the kind of patients where you want to have pacer pads in place, because they can actually quickly deteriorate to a third degree or a complete heart block. So just kind of having that caveat there. But if you do have signs of hemodynamic compromise, the patient's altered, you're going to kind of want to go over to this side of the algorithm tree here. And there's really two branch points here. So if the patient's in a sinus bradycardia or a Mobitz type 1 second degree AV block, this is a patient that can be managed first with atropine. So we start at 1 milligram dosing, and you can repeat that every 3 to 5 minutes. Important to note that the max dose that you can give a patient is 3 milligrams. If the patient is persistently bradycardic after you give your atropine, this is a patient that you're going to want to make sure you have pacer pads on, and transcutaneously pace the patient with a Zoll machine, and your seniors can kind of help you out with getting that set up and working the Zoll machine. That's kind of a talk for a different time. Additionally, what you can do is add beta adrenergic drip, so dobutamine, epinephrine. Dosing is over here, and we'll talk about that more in a second, but for dobutamine, it's 5 to 20 micrograms per kg per minute. Epinephrine, you can start at 2 to 10 micrograms per minute. So if you're in this sinus or Mobitz type 1 second degree AV block tree, and you're persistently bradycardic despite transcutaneously pacing or adding these drips on, these are patients that you're going to want to start escalating care pretty quickly, especially if they have evidence of hemodynamic compromise. And what you can do is call your cardiology folks, get some transvenous pacing in. This is a patient that probably will need an electrophysiology consult or evaluation for possible permanent pacemaker down here. So if the patient, kind of going back up here, so if we have a bradycardic patient and you deem that there's hemodynamic compromise, and you find that the patient's in a Mobitz type 2 second degree AV block, it's important to note that atropine typically is not effective in these patients. It's thought to be that the block is maybe infranodal, so atropine wouldn't work, and that's kind of where you want to start your beta adrenergic drips on right away, just kind of skipping the atropine step, and then you can go down to transvenous pacing, and then go down to if the patient needs a permanent pacemaker. And kind of what I said over here, these patients, these type 2 second degree AV blocks are at increased risk for kind of deteriorating to a complete heart block. So these are patients that you're going to want to pay close attention to. And lastly, if you have a patient that is bradycardic and you find that is in complete heart block, again, you're going to want to do the same kind of step here. So assess, if you're worried about hemodynamic compromise. So if the patient is stable, you can trial atropine. If that doesn't work, and again, going up to the 3 milligrams, you can go down the tree here, transcutaneous, transvenous, permanent pacemaker. If the patient's unstable, that's kind of where you're going to want to straight go to probably a pacing type therapy. So that's kind of the big algorithm tree here. Kind of in this paradigm, you're going to want to make sure you assess for why the patient is bradycardic. And there's a whole host of reasons. I'm sure everybody remembers from med school, but I kind of wrote a couple here. So the first thing is making sure that they're not on a medication that could be precipitating all this bradycardia. Are they on a beta blocker? Are they on a antiarrhythmic medication? Did the patient have a vasovagal episode? Checking a thyroid panel. Are they hypothyroid? Checking their electrolytes. Assessing for evidence of hypoxia or hypoxemia, putting that patient on oxygen, ischemic heart disease, and infiltrative cardiomyopathy like sarcoidosis or amyloidosis, things like that. Short talk, but this is kind of the management of bradycardia. Happy to answer any questions that you guys might have, with this, but best of luck moving forward, and just feel free to reach out, okay?
A quick review of the rhythms: sinus bradycardia, heart rate less than 60, normal PR interval. Second degree AV block type 1, also known as winky back, progressive prolongation of the PR interval until a QRS beat is dropped. Second degree type 2, where QRSs may be dropped irregularly without necessarily a PR interval prolongation. Complete heart block has complete dissociation between P waves and QRS complexes, a dangerous rhythm. Remember the reversible causes of bradycardia, H's and T's from your ACLS, and review them after you stabilize the patient.